Well, I'll start with the latter. So the immediate impact for us is the Medicaid base rate puts us about $300,000 in the hole, so it's a cut of about 300,000. So that's the good news, I guess, in a way. The bad news, of course, was the original proposals from the Senate and the House ranged anywhere from a $13 million cut to a $3 million cut. So I guess to land at $300,000, I think, is actually pretty good. Now we've been able, and you may get to this a little bit later, we were able to pick up probably an additional $12 million in LIP funding. So that's very significantly, that's been very helpful for our organization, obviously, once things sort of play themselves out. I think the toughest part is, this is a yearly exercise. And so every year, I think healthcare comes under the radar screens, or comes on the radar screen for folks, and we try and figure out we're going to cut the base rate, we're going to change the formula, we keep changing the model, and it'd be great if we established as an organization, as a state, and said, okay, this is kind of our strategy around how we're going to fund healthcare, and then do it for a couple of years or 5 years, whatever the case may be, and not really have to play with the formula every year. I think it's very difficult for organizations like mine, safety net organization, teaching hospitals, to know that every year your budget's going to be a moving target. What would be great is if the legislatures actually got with the hospital leaderships and sort of the other leadership around the state and said, okay, what do we want to do? Kind of what's our strategy for the next 5 years? What do we want to fund? How do we want to fund it? What's the model we want to use? Get with the hospital leaders and physician practice leaders and say, okay, here's where those benefits, let's put together the right task force that says, let's think through this. And then we establish what that formula and the model should look like over the next 5 years. Right now, what it looks like is every year, depending upon who's in charge, this is the direction we're going to go, and then we switch to a different direction. And then, of course, every 4 years with a new change in governor, if there is a change, then there's even a wholesale switch. So I'd like to see sort of a model that says this is the formula for the state of Florida. This is what we want to do. What are our Medicaid base rates and how do we want to establish them? Do we want to use LIP and DISH and other supportive elements? Do we want to do the physician supplemental payment? And let's go with that and say this is how we're going to support healthcare over the next 5 years. Because what ends up happening is at the end of all of that, the patients are the ones who are struggling, right? Because we're trying to fund certain things, we may not be able to support that, and the patients end up on the short end of the stick if we just don't have the resources necessary to provide care. So we don't ever want to be able to say, we have to close this clinic or this service line, whatever the case may be. So we struggle to not be able to expand them the way that we really want to, right? Put all the resources necessary. So, for example, we're recruiting a new vice president for community engagement. So we want to be able to engage the community more. But that person is going to have sort of a limited budget to what those relationships with the community should look like. What other partnerships can we create? So I think that's important. We've got $85 million in requests for brand new equipment for the organization. I have about $10 million to spend. So that means every year I've got to look at what are the $10 million I have. I've got $85 million in requests, and how do I, distribute that appropriately? And so every year, some things get a little bit older. So that's part of the dynamic, and so we have to then sort of replace them, and sometimes we run things a little bit longer than we need to. We partnered with the city, as most people know, for $120 million in infrastructure funding, and that's been very helpful, or will be once we really start working on the projects. But we have lots of other infrastructure needs on the campus, quite honestly, that we can't get to. So the struggle is we can't do all the things that we really want to be able to do. But if we keep going through an exercise of, okay, we're going to take money out of the Medicaid base rate or change LIP or whatever, then you start to get into real tough decisions where we may not be able to provide all the things we want to do. I think it remains to be seen. Obviously, you've removed a lot of the barriers, or if not all of the barriers, for creating competition and creating a non-hospital. I think, again, this is that overarching theme. How much healthcare do you need? So, the challenge is, how many hospitals do you need? How many more hospitals does the city of Jacksonville need? How many more hospitals or beds do we need in the region? The risk always with CON is people carving out certain niche things, like, okay, we're going to be this kind of hospital, and we're going to be in a location where the payer mix is great, and then organizations like ours and a few others that take care of a heavy Medicaid version, that's all you're left with. And so that's part of the challenge. it means somebody, for example, at our north location could put a hospital right across the street now, and there's nothing that can stop it. There's no regulation, and I can't do anything about it. And then how many hospitals do you need in North Jacksonville right now? Population is growing there, but do we really need a second hospital or even an ambulatory surgery center? So I think the risk is that you end up with too much healthcare, and I'm not sure it's going to do. And then in the end, I'm not sure it's going to reduce the cost of healthcare, like what the thought process is. You have to look no further than Texas, which hasn't had CON for a long time. And if you go to the city of Dallas, city of Houston, there's an emergency department on every corner. It's still expensive to go there. I'm not sure their healthcare is any cheaper. Yeah, I mean, there's no question that hospitals like ours across the state and the region use advanced practice professionals, whether those are nurses or physician assistants, optometrists, and numbers. And I think there's no question that there's a place for advanced practice professionals in healthcare, particularly in certain rural environments. That being said, we don't want to get into a scenario where we're trying to replace physicians. And I think that's the risk. And I think there's an unrealistic expectation that, we just replace a physician with a nurse practitioner or a physician assistant. I think that's the danger. I mean, people go to medical school for a reason. They go for high quality education, 4 years of medical school, 3 years plus of residency. So these are highly skilled people, and I don't think we can replace them just to expand the scope of practice. So I think we have to find, where we can expand scope of practice, make it appropriate, where it fits in the healthcare system, where it fits in the rural environment, and then versus trying to get into a scenario where we're trying to replace the physician workforce. So we've been using telehealth for a long time, and actually when we built our North Hospital, for example, every room is designed for telehealth. Particularly for consultants, for example, who may be at our downtown campus and can't quite get there. So every room has an iPad. It's designed to dial into any one of our specialists, so we've been using that. We actually got a grant, one of our faculty members got a grant from the Centers for Disease Control to study telehealth and HIV, and remove some of the stigma about a patient having to come in, but instead can dial up on their phone or an iPad. So we've been using it for some time. We've been using telestroke for a while as well, so that our neurologists can identify a stroke patient in the field. That actually has been stretched, and we've used that in southern Georgia as well, because there are patients who don't have access to acute stroke or advanced stroke care, and so we've been using it. So we've been on the telehealth kick for a while. This hopefully will allow us to expand it even further, particularly once you get rid of some of the reimbursement issues, which has always been the challenge. So as long as we're getting to a model where we feel like we can reimburse physicians for telehealth, I think that's great. So I think there's definitely a role for it. It helps with access, different depending upon the patient population. That's what they prefer. It's immediate, and so I think there's a particular role for it. I also think there's a role for it in terms of physician shortage. And so if you can't have, every county can't have an orthopedic surgeon, for example, or pick some other specialist. So here's a way to have access for care. And so hopefully that will allow us to take better care of our patients. The big thing is for us, I mean, we work very closely with Senator Bradley, Representative Cummings, to say Audrey Gibson, and really work very closely with them. I think they understand the needs of the citizens of Duval County and Jacksonville, and so it was a pleasure working with them. And so I would obviously encourage all of our physicians to continue to engage with their legislative teams and work closely with the DCMS and other advocates to support the needs of our physicians in our community.